Hello? Okay. Did everybody enjoy their long 4-day weekend? Dr. Seacard, you didn't get one, did you? I didn't get one. Pennywell. Y'all all got one. Y'all had multiple long days off. So for inguinal hernia, femoral hernia, there's kind of a, it may seem kind of simple because we do a lot of them, but it's kind of not. You gotta, for lack of a better way to put it, you gotta know your anatomy backwards and forwards, and I didn't really appreciate this. I feel like sometime as a resident, honestly, I don't feel like I truly understood it until I showed somebody else how to do it as a fourth-year resident. I could do the procedure, but in terms of truly understanding it, at least from the anterior approach, you know, maybe I'm just stupid, but I don't feel like I really understood it until then. It kind of clicked. So I have some pictures of you know, just some cartoons of the anatomy, but also since this is only a 30-minute lecture, pulled up some of those questions at the bottom of the pages on those score things, because I guess that is what y'all need to know for boards and oral boards and this, that, and the other, but didn't really feel like I could do everything in 30 minutes, so I apologize. Like I said, the anatomy, this is the anterior approach to the anatomy, so I apologize, I don't know too many of y'all's names up here, but what's your name? Lindsay. So what are the different types of, you know, what we typically call groin hernias? Okay, what kind of inguinal hernias are there? What you got? Okay, direct. So if there's a direct, there has to be a indirect. Okay, so what's the difference?
They're going through
I'm sorry, who's the girl sitting next to you who doesn't want to make contact with you? Sorry. Sarah. So what makes up the difference between a direct and indirect hernia? I'm sorry, I was distracted by my own cartoon picture. What did you say?
So it's whether or not it's either the internal or external.
Okay, so what is Hasselbecks triangle? They even gave you the name and make you say that. Let's see. What's your name?
Reynolds.
Reynolds?
Yeah, I like this. One side's the inguinal ligament. One side's here.
Okay.
And it has to do with it comes out lateral, comes through the triangle.
So a triangle has three sides, and you ain't two. So what's the third? It's even up there in that picture. Which muscle? There's a lot of muscles. Yeah, the rectus. So you have the, I don't know if this is, okay, you have the lateral edge of the rectus, which is the medial aspect of the triangle. The inferior part of it is the inguinal ligament, and then you can't see it here. Here are your femoral vessels. Coming off the femoral vessels and going up along your abdominal wall are the inferior epigastrics. So if there's a hernia coming right through that triangle, what is that? It's coming directly through that triangle. Yeah, very good. So if it's not coming through there, so where would an indirect be coming through relative to that triangle? Through which canal? Okay, coming through, so there's two openings to the canal. There's an internal and external. Which internal? It comes through the internal inguinal ring, which is relative to the borders of the Hasselbecks triangle lateral. So it's coming out lateral to the internal inguinal ring is lateral to the inferior epigastric vessels. So that's how, you know, when we talk about direct or indirect, you know, not a huge difference between those two words, but that's the difference in the anatomy. What's the most common, overall, what's the most common inguinal hernia? Indirect, okay. What about for females? Okay, good job. What about femoral hernia? Where's a femoral hernia? I don't even think I have a picture of that. I'm sorry, like a true one. Let's see. That may be a little advanced for y'all. Jim, actually, this is a formal setting, so James. Semi-formal.
Semi. Since we're wearing like this.
What about a femoral hernia? What are the borders?
I believe it's the femoral vessels, the adductor magnus.
You look like you don't want me to call on you, Andrew. Your head's kind of bowed. Oh. What about you, Andrew?
Do what?
I'm skipping all the other people in front of you, below you, coming straight to you.
Through below the inguinal ligament through the femoral ring.
Okay. So what are the borders? He named the vessels.
Okay, so the
Femoral
inguinal ligament
vessels.
anteriorly, the femoral vessels posteriorly. It goes through the empty space between the artery and vein. I'm sorry, the vein and the lymphatics.
Let's see, there may be a better picture. So this is from the, if you're looking at it laparoscopically, if you're looking at it from the inside up towards the abdominal wall. So here you have, so this is completely different for the students. You know, before we were looking at it from the front, now we're looking at it from behind. I don't know how many of y'all may have seen or are familiar with the different views, but so here's your rectus muscle. So here's the lateral border of it. Here's your inferior epigastric vessels, and here's your inguinal ligament. So here is your triangle. Look at that, it's three-sided, it's a triangle. So here's your direct hernia, anything popping through there. Lateral to it, lateral to the vessels, this is your internal inguinal ring or your indirect hernia site. And then below your ilioinguinal ligament, or sorry, your inguinal ligament or iliopubic tract is your femoral hernia space. So different view, but that also kind of also highlights the point with that when you're doing a hernia repair from the anterior approach or going from the outside in, it's difficult to really assess a lot of times for a femoral hernia. And sometimes, you know, when people have what we call a recurrence, it's not actually a recurrence. They had a femoral hernia the whole time, and we just didn't pick up on it and didn't actually fix the problem because it's a different approach to fix it. All right, man, that took 10 minutes already. Here's another picture. The wording is a little bit blurred because this is just from some internet site, and it's also black and white, so it may not even be as good. But anyway, that's the same thing. So there's two for, and also this is just more anatomy. I'm kind of skipping around, but for the laparoscopic approach, Awe, what is the triangle of doom? What do they call it? What would be the, so there's a triangle of pain and a triangle of doom. What would be in the triangle of pain? What would be in the triangle of doom? What would happen if you poked a hole in something in the triangle of doom? Why would it be doomful? If you poke a hole in something and you're not going to do well if we don't do something about it, like you're going to die, maybe, what would we potentially poke a hole in? See that big red and blue thing up there? Vascular structures, yeah. So that's what we call the triangle of doom. So it's bordered by the gonadal vessels, let's see, it's actually let me go back. So when we kind of splay out the gonadal vessels here and the spermatic cord here, when we kind of stretch those out like this, and this is the spermatic cord going through your internal inguinal ring for your indirect hernia. When we lay those out, and then back here is just going to be the edge of your peritoneum. This is our triangle of doom, and this is your vessels here, your iliac vessels. So if you poke a hole in them, if you put a tack in there to secure your mesh, all of a sudden you have brisk arterial bleeding, That's what I call the triangle of doom. And then there's also the triangle of pain, which is, I don't really like these pictures, I'm sorry I even put them in here. But you have your iliopubic tract or ilioinguinal ligament, and you have your testicular vessels and vas, if you lay that all out here, and then back here your peritoneum. So this would be your triangle of pain here. And whenever we're putting our mesh and our tacks in, we don't put any tacks below your iliopubic tract, because this is where those nerves live. And you put a tack in there or some little clippy device to hold the mesh in place. You can have somebody that just has chronic pain that won't go away, like Dr. Sid and I have at the VA right now. But I'm not sure what I'm going to do with it yet. So anyway, we'll skip down to the questions. Let's see, Jim, I'll go back to you since you didn't really answer the question that I asked you. If you're seeing a young athletic male in your clinic, what would be your approach to a symptomatic inguinal hernia, or how would it be different than an 80-year-old male? What would you offer the young athletic guy, whether he's an athlete or he's busy with his job and he can't take time off of work, he's healthy?
You said symptomatic though.
Yeah.
Define symptomatic.
He can only work 4 out of every Friday. He has to take off because he's just hurting so bad after 4 days of lifting bags of concrete.
Off on fixing it, watching weight.
Okay. What about you, Paul? What would you do?
Can you define do?
Well, as the surgeon, this guy's in your office. What would you do for the young, healthy guy that can only work 80% of the time because he's hurting so badly? Yeah, why?
Shorter recovery time.
Right. So what I tell people is, when we're putting the mesh in, if you do the old-fashioned open approach, you know, if here's your inguinal floor, you put the mesh on top of it. Anytime you lift something or cough or any sort of increased intra-abdominal pressure, you're pushing against your mesh. You're pushing against your repair. Where we put the mesh in for the laparoscopic approach, it's actually on the inside. And so anytime you have increased intra-abdominal pressure, well, the mesh is just getting pushed against your pelvic floor where the repair is. And so we always tell people don't lift anything over 6 pounds or over 10 pounds for 6 weeks. After any sort of intra-abdominal surgery, because your incision is healing and you may get a hernia, and the same thing for an open inguinal hernia repair. And that's the reason you risk recurrence, because it takes 6 weeks for that tissue to scar and heal as much as it's going to. Whereas with the laparoscopic approach, just because of where the mesh is placed and what happens anytime you increase your intra-abdominal pressure, you don't have those restrictions. Now, I usually still tell people to kind of take it easy for a few weeks, but if somebody had to, they can go back to work the next day and they can kind of do whatever they want. I tell them not to do that if they can, but if they had to, they could, and it's just because of where the mesh is placed and how it's seated and what's happening anytime that they lift or strain or anything like that. So like Dr. Molly was saying, you would offer the young, healthy guy a laparoscopic approach. He can't take 6 weeks off of work. His family's going to lose their home and their kids are going to go to child services or whatever because he can't feed them. So the approach to him would be different than an old guy with COPD and coronary artery disease. Why would it be different for an older guy that has a lot of medical problems? For a laparoscopic approach, what must we do anesthesia-wise? Yeah, you got to put him under general anesthesia. So if it's an old guy who's just, kind of sitting around at home building fishing lures, and he's got a bunch of medical problems, and you don't really want to put him to sleep for an elective procedure, but he wants it fixed, you're not going to want to do a laparoscopic repair because, the risks are going to outweigh the benefits. So what else? You just do the old-fashioned approach, and that guy, you just tell him, look, you're just going to take it easy for 6 weeks. Because what else can you do besides general anesthesia? I think that's a question later. Chad. If you don't want to do general, what can you do for a groin hernia, inguinal hernia?
Some lidocaine, some local.
Yeah, you could just do local. What else, Derek?
Epidural or something?
Yeah, you could do a spinal. I don't like doing it because I just prefer people to be asleep. because I usually forget if they're not and say things I shouldn't say, but you know, you can do it without general anesthesia. Okay, 60-year-old man, otherwise good health, presents long-standing massive inguinal hernia extending into the scrotum. It cannot be fully reduced. What are the potential operative challenges? What are the advantages and disadvantages of laparoscopic versus open? What types of anesthetic are suitable? Okay, so this is one thing we kind of see in clinic. What if, you know, you're working this up for whatever reason as primary care person, ordered a CT scan, and you see a big loop of redundant sigmoid colon extending down into the scrotum. And he's a 60-year-old, you're asking him questions. What's one important thing for this guy with some colon in his hernia? Preoperatively, you're going to want to know. Okay, if there's an obstruction, and it's I'm kind of just asking y'all to tell me what I'm thinking. The residents probably, hopefully know. And in private practice, I don't know if they do this, but I know in an academic setting we always have, and I still tend to. I want to know if they've ever had a colonoscopy, and if so, how recently. Because if I'm going to be potentially manipulating a big loop of colon, you know, you may injure it. He may come into the ER one night, you know, before you fix it, and it could be acutely incarcerated and strangulated. If there's a potential for having to do a colon resection, you know, I want to know if he has polyps or a colon cancer, because I'd hate to take him to the OR and do all this, and then, you know, in 6 months he gets a colonoscopy and he's got a big colon mass. I don't make it a hard and fast rule for the patients. I think, again, Dr. Sitt and I had a guy a couple weeks ago that we did fix his hernia, and he just refused to get a colonoscopy preoperatively. And you know, my concern was he definitely had, it was just a loop of small intestine, but you know, my concern was he was going to come into the ER one night with a strangulated hernia with dead bowel in it, and you know, it would be an emergent thing. So I just told him why I wanted the colonoscopy, but I wasn't going to refuse to fix it. I don't even know if that answered, really addressed the question that was asked by this. So what are you thinking about Patton, with this guy with a big loop of bowel, chronically incarcerated in his hernia? What do you have to think about in terms of the anatomy of it? Your sac, say this is an indirect hernia.
Chronically, you have to worry about like adhesions.
Adhesions and everything else. Are y'all familiar with what a sliding hernia is? What do we call a hernia? A slider. So there's a component of the hernia sac itself. So when we talk about the sac, it's just peritoneum that is. So here, if all this was this is usually just covered with peritoneum, and I don't know if y'all have seen it, but I do, for the laparoscopic, I do the preperitoneal approach or the Dept. But either way, this is all just covered with peritoneum, so we actually have to kind of peel the peritoneum back this way. Well, what's coming through your internal inguinal ring for your indirect hernia is just peritoneum. And so when we're dissecting that sac out, you know, that's a connection to the peritoneal cavity. Well, all the colon and guts and everything live in the peritoneal cavity, so sometimes that sac of peritoneum can slip down through your internal inguinal ring for your indirect hernia and actually drag a retroperitoneal structure with it. You know, the wall of the bladder, the cecum, you know, some sigmoid. And so part of the sac can actually be made up of a visceral structure. And so, you know, usually, hopefully y'all maybe not, but you know, usually what we do for the open repair is we'll have the sac kind of laid up like this. We just put a suture through it, ligate the edge or the base of the sac at the internal ring. We excise the redundant sac and just let the rest fall back in. Well, if part of that sac is made up of, you know, sigmoid colon, we can't do that. We're going to bovie through colon, and then there's going to be doo-doo all in the wound, and we've created a huge problem. So what if it's so that's a sliding hernia. It's a component of it is of the, you know, visceral structure is slid into the internal inguinal ring and with the sac. So what do we do in that situation, Eris? I skipped you, Amos.
You're doing an anterior approach or laparoscopic?
Yeah, it's going to be much more difficult to do laparoscopically. You're going to really risk injuring whatever that visceral structure is. And I feel like I'm kind of talking over y'all's heads now, because maybe y'all seen a laparoscopic hernia repair, but unless you kind of know what you're doing, and have done it. And I'm not trying to talk over your heads, but
So if you do it, I guess if you're going in the anterior, you notice that you have sigmoid in your hernia. I guess you try and reduce it, like get it off the peritoneum. You can't. You can do the Baroque or make an incision 2 centimeters above the inguinal ligament and go intra-abdominal, try and reduce it that manner.
well, okay. So say it's reducible, but you just have, you're trying to deal with your sac at this point, and you can't just perform a high ligation of it. What are you going to? Because part of it's made up of whatever. What are you going to do? I'd ask Amos, but we've done this a lot recently at the VA, so I know he knows the answer.
So this is not reducible, or it is reducible?
It'll reduce, but you have to address the base of your sac. Like rather than just having peritoneum coming up as your sac, that you can just put your silk stitch through and tie it around, ligate it, excise the redundant sac, and let it fall back in.
Imbricate it?
Right, you just imbricate. You excise as much of the sac as you can, you imbricate the edges of the peritoneum back over that visceral structure, and it'll just, more times than not, it'll just fall back in. And if it doesn't, then you can just, if it doesn't want to fall back in, you can always just cut this at the internal inguinal ring. You can just make it a little bit bigger. Sometimes we have to do that in the acute setting when the intestine or whatever it is that's herniated through there becomes very edematous and doesn't want to dunk back in. But usually in an elective setting, it'll always go back. This is familiar. 1 month after an open repair of an inguinal hernia, a patient presents to the clinic with intense pain under the incision radiating to the scrotum. Made worse with movement and coughing, there is no obvious mass, and you note no signs of infection, but even light palpation of the wound causes patient significant pain. What are the possible diagnoses? How will you proceed? Dr. Zachary, I believe that one of our patients keeps coming back to my clinic limping with a cane from like August. And I'm running out of time to just keep telling him it'll go away, it'll go away. Give it another month, the inflammation will die down.
Right. Yeah, so it sounds like
So he was I'm going to say he was a laparoscopic repair.
Sounds like we'll probably impinge one of the nerves, and then you can either do a block to test it. If that works, you can re-explore and try and isolate that nerve. Go in the original wounds. Some people will do it either laparoscopic or just come from more lateral, but I have zero experience with either of those.
What do you do laparoscopically? Because I've had to do it for one of my opens, and I just extended more lateral on the open. But that wouldn't be helpful if you were laparoscopic.
Yeah, that's the problem. I've had to actually do a little bit of reading because I'm like Joseph. I've never personally dealt with it until now. So we tried a block. And the guy took a pain pill, so he couldn't really tell us because at the time we did it because he said he wasn't hurting when he came in that morning anyway. But he's supposed to be coming back to clinic. I don't expect the block to have really worked because, like Ariel said, if you approach it laparoscopically and you have a impingement on a nerve from that approach, doing, the nerve block is, the diagnostic nerve block is traditionally for, if you bag the nerve from the open approach. Going back in laparoscopically, I think we were using those secure straps at that point. So if we put one of those straps on the nerve, or if it got scarred in, go in and try and remove any clips and.
Aren't those absorbable? It's monocryl or vicryl or something, right?
It's monocryl, yeah.
Well,
that should have been.
I'm wondering. Part of me wants to say this guy's just full of it.
I think he's malingering.
Okay, yeah.
He may be. And I'm just a big softy, so I can't tell him just suck it up and go back to work. What about you, Beth? Have you?
I know Griffin's pulled a tack out that was done elsewhere in about 3 days, but.
And that's the thing is this guy's kind of like this. He came back first 2 weeks after surgery and was fine, and then he was turned up at the ER. He may have gotten online and done some reading and figured, oh, I can get disability from Walmart if I go complain about this.
this guy apparently like woke up from surgery going, ah, I guess.
Yeah. Yeah. So anyway, my saga with this guy is not over. I'll let y'all know how it goes. Let's see. What do y'all students, what do y'all think about this question? Should all patients with inguinal hernias undergo operative repair? Cite evidence. Y'all don't have to cite any evidence. But it's kind of what the guys in the back were originally talking about in terms of, you know, when do you fix it? When do you just let it go? What do y'all think? If you had a 40-year-old guy who's active and working and has kids and is, I don't know, Dr. Griffin just came in, and I'm probably going to get harshly criticized for anything I say about inguinal hernias.
No way.
You know, it's reducible, it's small. Let's change the scenario a little bit. He's 65. He's got a few medical comorbidities. You know, he's asking you, what should I do? Should I get it fixed? Should I let it go? You know, I try to be fairly active. I like to fish. I'm retiring next month. My wife has a lot of projects for me. But, you know, should I have this fixed or not? What do y'all think? What would be your discussion, you think, with somebody like that? And it's you know, it's not black. It's not a black and white answer. So, yeah, it's reducible.
See how symptomatic they are from it.
I mean, he's got some discomfort, but, you know, he says, I can live with it if I have to. But he's also willing to have surgery if you think it's the best thing to do. Yeah, you could, and I think it boils down sometimes to just the opinion and experience of the surgeon, and this may be where, you know, a comment from Dr. Griffin may be helpful, even though he's apparently walking out the door in the back. Yeah, I mean, sometimes I used to have the approach of I mean, it's small, it's less than 5%, especially for, you know, a small, minimally symptomatic, reducible hernia. You know, if you've got one with a huge scrotal component, kind of like that guy I was talking about at the VA, it's going to be much higher. You know, the risk of strangulation is very small, you know, low single digits. But for this guy, and this is just, you know, and I tell him that, it's like, you know, there's always a small chance you could come in the middle of the night in the ER and you've got dead bowel in your hernia and it's an emergency and you're going to get a crappy repair because we can't put mesh in, and then it's going to recur and we're going to have to do a different approach and it's just going to be a miserable experience. But that's very unlikely. But what I tell people is, you know, for these guys that are doing okay with health, but they're only going to get older, their medical problems are only going to get worse. If it's in any way limiting to them, I'll go ahead and encourage them to get it fixed, just because, you know, my opinion is you're never going to be as healthy as you are today. And now if they're, you know, 88 years old with 6 stents in their heart and they're on Plavix and they are on a home oxygen for their COPD, I'll say, no, like, you know, just wear a truss, which is kind of like a little jock strap device with a thing that presses on their inguinal ring. But that's how I approach it. Samra, Duhan, Dr. Weigel, y'all differently. What is that in agreement to, Dick?
I agree that you're never going to be as healthy as you are now.
Yeah.
And, you know, while we know all in the literature that says, what's the chance of strangulation? It really isn't that high. So to tell somebody, oh, you've got to get it fixed because it might get strangulated is really crap. But the other response is, it's only going to get bigger.
Yeah. They're not going to get fixed without surgery, you know, so that's my take.